Good evening and welcome to the Utah Political Hub's Smart Questions Club. Tonight we're talking about Medicaid expansion in Utah, and we brought on two guests to talk about their perspectives on the issue and what questions they want you to be thinking about as you consider whether or not you should support Medicaid expansion. Been in the news for a long time with more or less intensity, and in the next few weeks or so we expect to hear that the governor may or may not call a special session for the state to address some form of Medicaid expansion. As that happens, we want you to be prepared to think about the issue, think about the things that matter as you're evaluating them. Our first guest tonight is RyLee Curtis. RyLee, please go ahead and just introduce yourself and tell us a brief bit about you and what's your relationship to this issue.
Yeah, so thanks for having me. This is a really great opportunity. My name is RyLee Curtis. I'm the Senior Health Policy Analyst for the Utah Health Policy Project, better known as UHPP. We're a nonpartisan nonprofit organization based out of Salt Lake City, Utah. And we have been working on this issue since the beginning, really, about 3 years. I've been working on this issue. In 2010, the ACA was passed. In 2012, after states like Utah challenged the constitutionality of the ACA, the Supreme Court ruled ultimately the ACA was here to stay, but Medicaid expansion would be optional for states, thus creating what is called the Medicaid Coverage Gap. And just real briefly, about 53,000 Utahns fall into that Medicaid coverage gap. They earn too little to qualify for help on healthcare.gov, but they don't make enough or otherwise don't qualify for Medicaid in the state of Utah.
Thanks, RyLee. We appreciate your time. We know it's late, but I'm grateful to have you here. Cameron, on the other side of things, please introduce yourself and tell us a little bit about how you relate to this issue.
Thank you again for having me on. I'm Jack Robinson. I'm an interested party, I guess. I'm an accountant by profession, controller for a private company based out of Draper. I live in Eagle Mountain. Was recently just finished my term as the treasurer of the state Republican Party.
And just speak up a little bit when you speak, Cameron. Maybe wake up your kids as you're talking there. All right, so we briefly heard RyLee start to introduce the issue and where she is on things. Just as a preliminary issue, and this has been here for a few years, I don't think if you're following Medicaid expansion that this is a new topic, but for those who aren't, why do you believe that we should go ahead and take expansion of Medicaid in Utah, and if so, in what way? Full expansion, the plan that the governor proposed last session called Healthy Utah, something different. What's your take? And go ahead, RyLee, why don't you kick us off?
All right. So yeah, when the ACA was passed back in 2010, there were a slew of taxes that were passed as well to help fund the expansion, the implementation of the ACA. Now, of course, as I mentioned, when the Supreme Court came in and said Medicaid expansion was optional to states, they did not say, however, that the taxes states were going to pay were optional. So therefore, we are paying all of these taxes to the tune of about $600 million per year to the feds to help pay for the ACA, but we don't pay any less taxes because we have what the state of Utah has been doing for 3 years is essentially say you as a taxpayer don't like a tax that the government has levied on you, and so you're gonna fight them by saying, I'm not gonna take my tax return at the end of the year. I'm just not gonna take that money the government's gonna give back to me. And what's even worse is that, as I mentioned, 53,000 Utahns are caught in this gap who we have the funds to help if we just said yes. Now, by way of which plan that our organization supports, we have supported full Medicaid expansion all along, but we are pragmatic. We work with both sides of the aisle, and we realize that we have a very conservative state here, and if the only way to get this done is to pass some type of hybrid model like the governor's Healthy Utah plan, which has very conservative principles in it, like utilizing employer-sponsored insurance, the private health insurance marketplace, has higher co-pays higher individual responsibility, then so be it, as long as these people get coverage and we bring back the taxpayer dollars that belong to Utahns.
Excellent. Thank you, RyLee. Cameron, what do you think? Should Utah take full Medicaid expansion? Should they take part? How do we address that gap that RyLee has pointed out to? Is in between what is covered and what is not?
I would say no. We shouldn't expand Medicaid, and I would even go no to the governor's Healthy Utah as well. As far as the coverage gap is concerned, this is a population that is it's not a newly created gap. It's been there for as long as Medicaid has been in existence. Frankly, it's what happened is that the ACA was passed, and they created these exchanges. Care exchange premiums, your monthly health insurance would get a subsidy. The government, the federal government, would pay all or part of those months.
Speak up just a little bit, Cameron. We're having a hard time hearing you.
But they put a floor on that, and now the intention of the ACA was to it was mandated in until the Supreme Court for states to expand Medicaid to cover the rest of the people that were in between. So these are folks that it's already didn't have insurance, already didn't, and so these are the folks that fall into that gap. And so that what the federal government wants us to do is expand Medicaid so that we can cover all of those extra people. Now, the debate is what's the cost? Once it became optional, a lot of states started balking at how much it costs. If we don't take up 30% of the state budget within a few years. If we do expand, full expansion, it'll obviously take up much more than that, unless we raise taxes or something like that to pay for it. So there's a big financial component that our legislators will have to grapple with to figure out how to pay for this expansion, which is why it's never been expanded before, which is why this gap has always existed, because it's really expensive.
Let's talk a little bit about that gap. So, RyLee, if I recall right, you cited the gap of 53,000 is what your number is at. How
yeah, and that's for 2016.
In 2016, it's 53,000.
Yeah, and if I can jump in here just for a second, Dan, when you talk about that gap, that's the gap between who is receiving Medicaid, who's eligible for Medicaid right now, and who would be eligible under full Medicaid expansion. There's a difference of 53,000. Is that?
So the gap, when we talk about the Medicaid coverage gap, the best way to describe it is single adults without children who don't qualify for Medicaid and parents with children in the home who don't qualify for Medicaid. So in Utah, parents can qualify for Medicaid if they earn between 0 and 50% of the poverty level. So for a family of 3, that's between $0 annually and $10,000 annually. Parents in a family of 3 who earn between $10,000 and $20,000 annually fall into that coverage gap. And then for single adults, the gap exists between 0 and 100% FPL. And so that is anywhere from $0 annually to about $11,000 annually. So that 53,000 are those people who can't qualify for Medicaid because they earn too much, and they also cannot qualify for help on healthcare.gov. They don't have those subsidies that Cameron was talking about. And I do agree with Cameron that Yes, they're in this gap. So Medicaid's here, ACA is here, and I agree with Cameron that the gap has always existed, but the federal funds to pay for this has not, and that's what the ACA created, was funds to pay for this.
So one of the questions that often comes up is what happens if there's a woodwork effect, right? This is the effect where there are more people out there than what we estimate. I think Kentucky took the expansion, and it was very popular, and it worked out well for those people in that gap. But the number was much higher than they expected. I think it was up to double. I think they started at 147,000 people. Kentucky's not a rich state, and it ended up at 310 by the time they, I think 2015 or 2014.
Yeah.
What does Utah do? And Cameron, feel free to jump in here if you have some thoughts too. But go ahead.
Yeah, just real quick. So the woodwork effect are people who are already in a state for Medicaid or not. So these are people, like I said, parents with children, people with disabilities, aged population over 65. So those people are the woodwork effect, but also children. And in the states that have higher than children ones who have estimates up, and that's because when parents go to see if they qualify for these programs, they're finding out that their children also qualify. And a large portion of Utah's estimated woodwork effect is, in fact, children.
How large do we estimate that woodwork effect is going to be?
So I've got my numbers right here. So we're talking about one 30 anywhere between
I'm sorry, you cut out there for a second, right? I lost you. You can just say that number one more time.
Oh, sorry.
Is it just my connection?
About 80% of those are children.
Okay. Cameron, thoughts?
Yeah, a couple of things. One is the woodwork effect is a very real issue when we're trying to project the size of this program. And so every state that has expanded, they've tried to calculate and figure out what the population would be that would sign up for Medicaid through the expansion, and just about all of them, if not all, have underestimated what that woodwork effect would be. And so there's been a lot of issues with cost overruns and things being there being a lot more take up than what they expect. And so I think that's one of the things that's making the Utah legislature a little hesitant to get on board. They're the ones who have to balance our budget every single year. And if you've ever gone to the legislature and gone into any of those committee meetings, and there's a line of groups and organizations who go up there and ask for funds for very worthy things, and the legislators are the ones who have to pick and choose. And that amount of money that they can spend every year, and they've got to decide how to do it. And so having that type of uncertainty is frankly. So one other thing I'd like to interject is on and Governor Herbert has brought this up as well as a way to push for his Healthy Utah expansion, is that with Obamacare they've instituted or created these extra taxes and partially to pay for this Medicaid expansion. And so we haven't expanded, and so we're being taxed and not using that money, which is a fairly good argument, and I applaud Governor Herbert for using it. But the problem is that every year since those taxes have been placed, the federal government has run a deficit. They've spent more than the revenue that they've brought in. And so we could say we've created this new tax to pay for this program, but we're already in the red, and so it's not as if there's this extra bucket of money filling up with dollar bills that we're refusing to use. It's all borrowed money until the federal budget gets under control.
But does that mean that essentially, I mean, we're running a deficit, but is Utah are they basically balancing or attempting to balance, that budget deficit on the backs of states like Utah who are standing on principle?
Well, no, because Utah generally is a net receiver of federal funds and not a net giver, even with these taxes. And there's different ways to look at that based off of how much public land that we have, and we get replacement money for all that and so on. But Utah gets more money from the federal government already than what it gives, and so no, the federal government is not it's not trying to balance its budget on the backs of Utah.
This is something I heard a lot, and RyLee, I think you alluded to this in your opening about how we're already paying the tax, but this is a way we bring it back. Now, if I understand that right, the tax is paid, but the money that goes out is only, I think it's a 1-to-9 ratio. We pay out $1 and $9 come back. Is that correct? What happens when that ratio changes, and is it sustainable?
Okay, so you're exactly right. So for the first 3 years a state chooses to do expansion, there's 100% federal match rate. So the state essentially doesn't have to pay for the first 3 years. But we are 3 years into this, so we don't get that option any longer. And so what happens is starting this next year, 2016, through 2020, the state share gradually goes up from 0% to 3% until it gets to 10%. So essentially the federal government will pay 90% of the costs in year 2020 and beyond, and the states who expanded will pay 10% of the cost. Now, some have argued that, of course, that's maybe not sustainable. The feds can't continue to do that. And so what happens if, they renege or they say, you know what, we're going to go to your traditional match rate. You're going to pay 30% of the cost. We're going to pay 70%. Now, that's why states like Arizona, also very conservative state, put in a circuit breaker when they did their Medicaid expansion. Meaning if that happens, then the state can pull out of expansion entirely. And, of course, people have issue with that because how can you give a benefit and take it away? We've done that in the past in Utah. That's been a sticky situation. But I can tell you I know quite a few Utahns who would take a benefit for a few years if that means they can get better and get back on their feet and become productive members of society.
There's a question with Governor Herbert's Healthy Utah Plan is a 2-year pilot plan, and it has this firm way to end it if we feel like it's not working, but it's the likelihood of that is really, really slim. I don't, in the case of Arizona, if the federal funding goes down to 70% instead of the 90%, and there's no way that they're gonna back out of it. It's just I can't imagine that happening. They'll either take money from other programs from the state budget or they'll raise taxes to make up the dip. Now, you can argue the likelihood of that happening, of the federal government reducing its portion. I frankly don't see that happening in the near future. If you look at the federal budget, it's got some real big structural problems that have to be dealt with, but I think they'll band-aid it and patch it together for as long as they can, and at some point down the road they'll have to fix it. But in the relatively near future, I don't see that ratio dropping. But frankly, it's hard to believe anything that comes out of Washington D.C. when it comes to finances.
We've got a cynic here and a hopeful optimist.
I would say too. I mean, if you look since we did Medicaid in the first place, since 1965, the federal government has never backed down on their federal match rate for the state of Utah, and we actually have one of the higher ones. They've always paid their 70% share, and in fact, during the recession, they actually increased it so that we had enough funding to support the people in Utah who needed coverage. And I think also to your point, Cameron and Kurt, I think that the Committee of Six recognizes that it is hard to give a benefit and take it away, and I don't think that I think they've kind of walked away from that 2-year pilot that the governor originally proposed.
RyLee, you're so diplomatic. I go for the gang of six. I can see them going sideways with their guns at each other, but I'll take your Committee of Six. That's much more diplomatic. Let me ask this of both of you. Kurt, jump in here if you've got a question you want to throw out there. What would expansion do for doctors? How does it impact providers' bottom line, especially if we get something like what is being talked about right now, that the providers will help pay for part of the taxes that are going to make this work? What happens to providers if this passes?
Well, one of the big problems with Medicaid in general, and it would just be exacerbated if it's expanded, is that it has a really low reimbursement rate, which means that as an insurance program, it pays doctors and hospitals quite a bit less, substantially less than private insurance and even Medicare. And so a lot of doctors will tell you that they maybe break even, if not lose money, when they treat Medicaid patients. And so nationally, you have something like a 30% or more rate of doctors who won't accept new Medicaid patients. And that would be
Did you say 30%?
Yes. Of doctors who won't take new Medicaid patients, and in fact, there's a nationwide in Utah, there's patients who have Medicaid as their insurance have a really hard time finding, particularly specialists for treatment, doctors in general, but especially specialists if they want to have something specific done. It takes a long time.
Can I just jump in here, Cameron? But doesn't having a Medicaid an assured payment also make it easier for doctors to predict, how they can plan their budgets when they're working with these people? I know in Nevada, when they, if I'm not mixing my states up, when they took the expansion, it added a ton of new patients who had health care in the first place. Not as many doctors, but it does bring a lot more clients to the front door. Is that something that doctors weigh as well? And maybe that's not even the right question, but first thing that comes to my mind.
So yeah, I mean, you'd have a group of people who didn't have insurance before, who did now, and so would be more willing to get services, and studies have been done for multiple groups, most recently in Oregon, that showed Medicaid patients saw a significant increase in the amount of services from doctors and so on. And so yeah, if you have a group of people who didn't have insurance before and suddenly do, they'd be going to see the doctor much more often.
RyLee, what are your thoughts?
Well, luckily we're not talking about adding to the medical. The G6 is 90 cents.
Can you hear Dan? I think we lost.
I can't hear RyLee at all.
Rate, hospitals getting reimbursed at a higher reimbursement rate, and doctors. Is it better if I hold the mic?
It might be. You kind of froze up there, and we didn't hear you for a moment.
So we're talking about private reimbursement with the G6 solution, meaning providers will be reimbursed at private health insurance rates. Hospitals will be reimbursed at private health insurance rates. They're not going to be reimbursed at Medicaid rates like other states have done. And that's one of the beauties of having waited so long to do an expansion, is we got to see Iowa and Arkansas do private expansions of Medicaid and how that worked for them. And we get to and actually improve it and make it better and work for Utah.
So who fills the gap? I mean, where does those higher rates come from? Is that just funded out of the state budget?
So it's paid for out of Medicaid, the Centers for Medicare and Medicaid Services, or the feds. They mandate that the state prove cost neutrality when they do a private expansion of Medicaid. So what you're talking about is, isn't it more expensive to reimburse at a higher rate? That is
Right.
true, but you have to find the savings somewhere else. And Arkansas was able to do that. At first, their rates were higher, but in the end, once the enrollment settled down, they were able to spin a, and we've actually had Mark and
We lost you again, Riley.
Her message was explosive. It killed the line. Are you there, Riley?
oh my god, yeah.
I'm sure it was a really good point too.
You started breaking up for me right when you said they have to prove cost neutrality, meaning they have to pull savings from somewhere else, and then at that point you trailed off. So if you want to.
Can you hear me?
Oh, now I hear you.
I can hear.
Okay, so yes, the state has to prove cost neutrality when they do something other than a traditional Medicaid expansion. Arkansas and Iowa have both been able to prove cost neutrality by pulling savings from other places. It was problematic for Arkansas at first, but once enrollment tapered down and they knew how much these patients were going to cost, they were able to, in fact, prove that cost neutrality, and that's been a big win for Arkansas.
So when you say pull savings from other places, like, can you give an example? I'm still not.
Yeah, I think it's, it's difficult to explain. So what happens is, as states expand Medicaid, they're able to see savings from, say, women who are not pregnant, they're in the coverage gap, then they become pregnant, they're on the Healthy Utah plan, they're not on a traditional Medicaid expansion plan, and so they're reimbursed at a higher rate. So states see savings there. You have cost savings with the criminal justice population, so reducing recidivism, making sure that folks don't circle in and out of the jail system. Ohio actually saw $10 million worth of savings there. So after states have expanded, they've seen all of these higher savings, and it's been able to kind of offset the higher cost of reimbursing the private market rates.
I can also see that there would be a great role in here for some kind of an inspector general over Medicaid to make sure that fraud is cut out and that there's not as much waste as there would be if in a situation where the dollar figures were not as high.
Right, absolutely. And Utah has an inspector general. We take pride in having really good accountable care organizations to make sure that we're not overpaying for services, and I think that there's a place for that as well in this expansion plan.
Okay, we've had you guys on here for at least for half an hour. Why don't you give us your closing thoughts in about 90 seconds? Cameron, would you like to kick it off, or Riley, who's been practicing this for a while? Have you got your stump speech all ready to go? Who would like to? Okay, we'll let Riley go first.
Oh, geez. I have been working on this issue for over 3 years now, and what I have learned is that sickness and illness do not care if you're a Republican or if you're a Democrat. They don't care if you have health insurance or not. They don't care if you're employed. Sickness can fall upon anyone, and all of us are paying for the uninsured right now. When people are sick, they go to the ER, and we're paying for that in our premiums. And so I think that now that we've got this extra funding offered through the ACA to cover these people, then I think that it's something that we can do, because a healthy workforce is a more productive workforce. And the last thing I want to say is that of these 53,000 Utahns, over 60% of them are working one or more jobs. And so we are talking about the working poor here.
Excellent. Thanks, Riley. Cameron? Closing thoughts?
Yeah, just in closing, we've talked a lot about the costs of the various proposals and programs that the governor and legislature and the Gang of Six are looking at, and that's a big factor. I think that's where most of at least from the politician's point of view, that's where most of the discussion has been, is how are we going to pay for it, and so how do we tweak the programs to make sure that there's funding available. But the focus ought to be on making people healthy and healthier, and I think that focusing on health insurance and making sure everyone is insured is the wrong direction, frankly. Health care is different than health insurance, and there's a bunch of studies over the years and in the very recent history that show that they're not equatable, and that simply throwing insurance at a whole bunch of people doesn't necessarily make anybody healthier. And so that's where the focus needs to in my opinion, needs to switch to, is come up with programs that focus on health. We can figure out a way to pay for a bunch of health insurance. Medicaid has been shown to be pretty crummy insurance as far as ensuring people's health. They have a difficult time getting access to health care, even though they have what amounts to free health insurance. And so I think that's where the focus has kind of been skewed and been taken in the wrong direction, is equating the two and forgetting that there's real people involved, and it's their health that we should be talking about.
Kurt, any final thoughts?
Yeah, just a few. I mean, first, I've enjoyed listening to everybody. You know, my perspective changed during the last 5 years, a good portion of which I was uninsured, along with my family. And I learned a few things. I learned that I probably overused insurance. I probably overpurchased insurance before, but that I was also just one bad luck away from complete financial disaster. And we got lucky. I mean, we went a long time without any health insurance and survived just fine, although our teeth are a little bit worse for the wear. You know? That was the main casualty. But to my experience, both what Cameron and RyLee has to say resonate with me, and where I have a problem with the Affordable Care Act, which is done and which is here, and I don't think is going anywhere, is that I think it has reduced some flexibility. Because one of the things I learned, you know, in my experience was that I didn't have to have the 80/20 $500 deductible plan that I had always paid for through my work. It's not what I needed, and now I mean, I can go a little bit lower than that, but it's kind of what I got to have, or I get hit with the tax penalty. But I think focusing on the people that are involved is the exact right thing, and I do agree with Cameron that that has kind of been missing, because ultimately, I mean, that's the exercise, right? This isn't really an exercise in, well, we want to achieve this policy goal and we want to stop them achieving from that policy goal. And what gets forgotten is that it's about people who have a sick child at 2 o'clock in the morning and they're like, can I take him to the doctor, or do I have to kind of ride it out and do a WebMD, you know, hope for the best? That's a tough position to be in.
Hey, there's nothing wrong with WebMD. That's what keeps my wife finding out that we're sick of things we didn't know about. Hey, I appreciate all of you. What's that, Kurt?
No, I just say I'll stop rambling now.
Not at all. RyLee, thank you so much. Cameron, thank you so much. We appreciate your time, and we look forward to finding out what happens. And maybe afterward we'll look back at it and talk about what the actual results are once we have a plan in place. Thank you, and have a great night.
Hey, thanks.